Let's start the timeout.
Patient identity confirmed.
Surgical site is marked.
Yes, marked and verified.
Picture this. You're lying on an operating table, the lights are blindingly bright, the anesthesia is just about to kick in, and your life is entirely in the hands of the people in that room. In those critical moments, a simple, unassuming piece of paper can literally be the difference between life and death. Welcome to this explainer, where we're unpacking a massive review of the surgical safety checklist. We're going to figure out, is this tool a genuine lifesaver, or has it kind of just evolved into another piece of useless hospital bureaucracy? To really understand the stakes here, we just have to look at the foundational data. When hospitals actually implement this checklist effectively, surgical mortality drops from 1.5% down to a staggering 0.8%. They essentially cut the death rate in half. And they don't do this with a new million-dollar machine or some breakthrough drug, but simply by getting the surgical team to pause, follow a structured format, and just communicate.
Section 1. Preventing fatal errors and what the checklist intercepts.
Okay, let's dive into this, because the mistakes we're talking about are literally the stuff of nightmares. The checklist is specifically designed to stop catastrophic never events cold. We're talking about retained surgical items, meaning a sponge or a gossipy boma gets accidentally sewn up inside a patient. It catches wrong site procedures and misdirected nerve blocks, ensuring a surgeon doesn't, operate on your left leg when the problem is actually in your right leg. It ensures the team doesn't miss that critical window for administering antibiotics to prevent severe infections, and it even catches equipment and hardware failures before the very first cut is made.
Section 2. Anatomy of a perfect checklist and what it should include.
So the core of this checklist is broken down into 3 absolutely critical phases. First is the sign-in, which happens right before anesthesia is given. Second is the timeout, which is a final pause right before the skin incision is made. And third is the sign-out, which happens before the patient actually leaves the operating room. Now, here's the kicker. What the research shows is that the sign-out phase is notoriously the most poorly adhered to. The teams are tired, the intense part of the surgery is over, and they start to rush, which is exactly when post-surgical planning mistakes tend to happen. And this brilliantly illustrates how the checklist can actually evolve. You don't just have to stick to the basics. The core safety functions, like verifying the patient's identity, marking the surgical site, and doing those final sponge counts, are totally non-negotiable. But hospitals have successfully adapted this for highly specialized fields. For example, they're adding procedures for what to do if a surgical robot malfunctions, ensuring blood clot prevention in neurosurgery, or verifying the correct lens implant for eye surgery. You can adapt it for sure, as long as you don't lose that primary safety purpose.
Section 3. Who owns the safety? The team factor.
This quote from the research is the absolute heart of the matter. The checklist isn't just magic paper. It is, fundamentally, a communication tool. For it to actually lower mortality rates, it has to be a meaningful, verbalized, inclusive process where every single person in that room is actively engaged in the patient's safety. It requires a truly flat hierarchy. That means the senior surgeon has to buy in and participate actively. The research is super clear on this. When the checklist is viewed as an annoying administrative burden and pushed entirely onto the nursing staff to just get it done, it fails. The whole team, surgeons, nurses, and anesthesia staff, must share this burden equally.
Section 4. Useless bureaucracy and the danger of the tick box.
Now, what's really interesting about this is the terrifying gap between what's written down and what actually happens. Hospitals love to boast a 100% documented compliance rate to satisfy management targets, right? On paper, it looks like a perfect safety record. But when researchers actually step into the operating room and measure the observed fidelity, what really happens, they often find this rushed, ritualized mumbling. The team goes through the motions like a script, but they aren't actually verifying the patient's safety at all. This pressure from hospital administration to hit perfect targets creates a massive moral hazard. It leads to something called pre-charting, where staff might actually fill out the checklist before the surgery even happens, just to get the paperwork out of the way. This completely decouples the checklist from actual patient safety, literally turning a proven lifesaver into a highly dangerous, totally useless paper exercise. Which brings us to the ultimate takeaway for this explainer. The surgical safety checklist is incredibly powerful, absolutely, but only when a hospital's culture values true safety over the illusion of perfect paperwork. So I'll leave you with this. Next time you or a loved one are on that operating table, is your surgical team actually communicating, or are they just checking boxes?